And now, here's your host, Dr. Randy Tobler.
Well, welcome to a snowy and blustery edition of Healthy University. Thanks for being with me. Heliene is on assignment this morning. So it's Elisa Kiger and Dr. T hanging out with you here. And we have good news right off the bat from Sarah Krause over at the health department, down to 4 COVID cases. That's great. And today in the hospital, we have no COVID patients. We have a robust census because, disease doesn't step aside for COVID, right? So there are other things that go on. And one of the leading problems in America, and it continues to be the leading killer, is, of course, heart disease, not only of men, but of women. Of course, February is American Heart Month. It's a time when all people can focus on their cardiovascular health. And so we hope to talk to Dr. Eliot Nissenbaum, our cardiologist from Blessing Physician Services, who comes to the Scotland County Hospital outpatient area. Many of you see him, and if you haven't, you probably should if you have a heart problem. And he's a great guy to get to know, and boy, he'll give you the once and twice and 3 times over. And I know I've had Dr. Nissenbaum evaluate me. He told me there was no hope, so I just keep counting the days, check my pulse.
He said you didn't have a heart, not that there was no hope.
If I only had a heart. And and anyway, so he's busy reading EKGs and PFTs, and we're waiting for him to come and join us as we will talk it up about heart disease, and with the little nuance and embellishment today of COVID-19 and how that can affect heart disease and long COVID and everything. Because of course, before you're a cardiologist, you're a internist, and before you're an internist, you're everything from a concert pianist to a mechanic to rebuilding carburetors. I don't know. He's a master of all trades. So we hope that he'll be joining us soon, and we'll just be waiting here, and because he's so busy when he's wait. What is this? Hello.
What is this?
What is this?
In studio?
Oh my God, it's me.
Walking into the studio, it's Dr. Eliot Nissenbaum.
That's me
with his
playing.
little portable piano. You can buy these electronic pianos now that are like guitars, and they hang off. Mm-hmm. Is that you?
This was a concert I gave 2 years ago, in Macomb at the country club out there.
Oh.
And this, you could Google it, just do Eliot Nissenbaum piano on a Google search, and this is the video that comes up. You can listen to this anytime. I gave this piece about 40 years ago back in New York City. I gave this piece here.
It's fantastic.
But this is, we had about a few thousand people listening to this, actually.
Dr. Eliot Nissenbaum. And, well, thank you for that. Appreciate that. We'll probably come in and out with some more interludes with selections from Dr. Nissenbaum. So you wanted to be a cardiologist, like in the bassinet at the hospital, right? I mean,
yeah, actually, it's interesting. I've always wanted to be a cardiologist, but I always wanted to be a concert pianist. So what do? I first started out as a concert pianist, or we're working.
Well,
in
they
that
both
direction.
have a commonality, because when you play the piano the way you do, it tugs at your heartstrings.
You could say, I'm what's called a perfectionist. In other words, I want to make sure that I hit the right note and not make a mistake.
Yeah.
So the same thing with cardiology, and people. I have about 2,000 patients in my practice right now. I've never worked this hard in my life. 2,000 people. It's amazing. In 4 different clinics. Basically, I'm the only cardiologist covering the whole 136 corridor from Memphis, Missouri, all the way out to Macomb, Illinois. And the 4 clinics are Memphis, Cahokia, then Hamilton Warsaw Clinic, and Macomb. So that's 83-mile expanse from one end to the other. But we've accumulated more patients. I've never had this many patients in my practice ever in my life. And I'm almost 60 years old, and I'm working like I did when I was 25 as an intern resident in New York City.
I know the feeling. Yeah.
You're a physician.
How come you still have hair and I don't? What happened there?
Genetics, I don't know.
Yeah.
My father had a full head of hair.
Well, let's get to the heart of the matter. Yeah. The one thing that I think has been underappreciated is the fact that during COVID-19, you've heard a lot about missed colonoscopies, delayed cancer treatment.
Yeah, it's a shame.
You haven't heard a lot about heart disease and, delays in either diagnosis or treatment there. And I think that that may be something that we really need to emphasize, because people may have subtle symptoms that they may not be aware of, right?
That's correct.
And they need to either see their primary care doctor, or if they're under the care of a cardiologist, they need to have a tune-up, right?
That's right, exactly. And in fact, I get a fair amount of referrals from the general physicians with patients that they are more short of breath after COVID, and they're worried that there's something with their heart that's going on here. So certainly at Scotland County Hospital, we have all kinds of tools to check their breathing, pulmonary function tests, things like that, and if somebody has underlying COPD, certainly it makes things worse for them. But the COVID, it affects the lungs in some people, not everybody, but some people. And if you already have a little bit of lung disease, and some people don't even know they have some lung disease, it kind of really brings it out. Yeah. So, and Dr. Wilson, I know he deals with this a lot in the hospital. He has to give steroid therapies temporarily, and just a run of steroids. And the outpatient doctors, of course, do this quite often, and the patients will get better most of the time. And if they don't, then obviously they'll have to get more treatment.
Well, we hear about comorbidities and how really, as the data has evolved in terms of who is likely to end up in the hospital, in ICU, or in a casket from COVID, it is either older people or younger people with, and the way I'm reading the literature, it's 2, 3, 4 comorbidities, but that's where the rub comes in, right? Because, for instance, I have hypertension. Okay, is that alone a comorbidity, or do you have to have hypertension that led to some kind of narrowing of your arteries? I mean, what really increases your risk in terms of heart disease and COVID, in terms of landing in the hospital?
It's actually both things, actually. It's interesting. COVID is a funny type of, as many people will tell you, and you'll hear on the radio, on the news, and internet. It's a funny type of a illness, because there are people that have just maybe a little hypertension, and boy, they land in the hospital, in the ICU. Other people, I've had patients, in fact, I think somebody right now that works in the hospital has bad COPD. Everybody knows her. I'm not going to mention her name, but she had COVID and she came through well. You know what I'm talking about. So how could somebody with severe COPD, and it not have to be hospitalized, and then somebody else who barely has a little hypertension and wind up in the ICU in Colombia someplace? It's incredible.
That's right. It's
very unpredictable.
It's unpredictable, and that's why it needs to. I think we're evolving to a place in COVID, the pandemic, now an endemic, that I think people have now developed a healthy respect for it rather than a fear of it, right? Fear led to, I think, a lot of overreaching reaction on the part of many people and jurisdictions.
Yeah, true.
But on the other hand, we don't want people to be complacent, right?
That's right. Yeah, that's true. And there's talk about, do the masks really work as well as they say it does? But yeah, the studies generally agree that masks are important. But then there's this whole thing now with the truckers and Canada. I don't want to get into politics. I'm not even going to touch that one. But generally, if you're in an area with a lot of people, I would certainly highly recommend a mask. Now with this Omicron, the Omicron is starting to wind down, as you said when you first started the show, that our cases are going down. But I think just a lot of common sense here. If you're in a large area and and let's say there's a lot of Omicron around the area, I would certainly try to avoid that event if you can avoid getting with a lot of people. But we'll see what happens. I won't even touch the idea of the vaccines. Some people agree with vaccines, some people don't. I get this question almost every day about the vaccines.
Okay, let's talk about vaccines, because, we know that the COVID virus, the SARS-CoV-2 virus, does tend to be associated with thickening of the blood and problems in the lungs. We know that the small vessels can get clogged. We've seen a high incidence of pulmonary emboli, and again, sometimes young people. But we also know, what happens in a heart attack, right? It's a blockage. It's basically a blood clot or a breaking off of plaque in the vessels. And so if you already have coronary artery disease and you have vessels that are a little narrower, right?
That's right.
I'm thinking of old copper pipes in a house, right? And then if you're trying to push honey through that copper pipe rather than water, is that a setup? Are we seeing more actual heart attacks, cardiovascular disease angina, heart pain, or not during COVID.
Exactly. And it goes back to what you said before. If you have underlying medical problems, certainly you're more at risk. But it's not an exact situation like I mentioned before about somebody. I know somebody has bad COPD and had COVID and barely affected them. The general trends is correct. You're right about that. That if you have those comorbidities, hypertension, diabetes, other things, you're overweight, you're more prone to get into trouble with a COVID infection. That's correct.
Okay. Well, we're going to look at that already where it's time for a break. We have to pay some bills, and when we come back, we'll hear a little bit more of our guest today's piano prowess, we'll call it, as he tinkles on the keys. And I don't mean in a urologic sense. Because, boy, it sounds like Liberace.
Well, thank you.
You ought to wear a shiny coat.
Oh, yeah.
With all the sequins.
Told me
amazing. That. We'll head out here, and then we'll go to a break here on Helping You. So thanks for being with us. It's 16 after the hour. We'll take you out here with a little bit of that and then head towards a break. Stay tuned. There's some of the amazing performance skills exhibited by our guest today, Dr. Eliot Nissenbaum. Born and raised in New Jersey, and then attending professional schools in New York City, ultimately settled in the Midwest. And down at Branson was the director of non-invasive cardiology there until coming up here to God's country up in northeast Missouri and I guess what would that be? Central West Illinois, right? At Quincy. And he's with the Blessing Physician Services. And we're thankful to have Dr. Nissenbaum here Wednesdays and Thursdays at Scotland County Hospital. If you would like to have a cardiology checkup that's very thorough, that will certainly make you feel that you have been evaluated very profoundly. That's important because this can be a hidden problem. And we want to talk a little bit about that with you, Eliot, because I know that a lot of this can be a silent disease, right? And
Definitely.
a lot of people, and it may have symptoms that people don't relate to heart as well. And since it's February is National Heart Month, proclaimed by President Biden in a national proclamation. And research continues to go into how do we prevent and treat it and catch it before it causes calamity. But I think, we should talk about primary prevention in terms of lifestyle, avoiding it in the first place. And then also, once you know you have it or risk factors for it, how can we prevent it from becoming a deadly problem for you? So let's start with lifestyle issues first of all.
Okay. I get this every single day in my practice. Numerous people ask me similar questions or would go in that direction. Those are called risk factors. Very, very important to address risk factors. If you have the person, you see somebody in church about 95 years old, and usually you're not going to see a 300-pound person, 90-something years old, because usually those people are 6 feet under many years before that. There's always one or two people that look like that and somehow make it to that age. But that's a risk factor, obesity, for example.
What is it about obesity that is what is it about carrying extra pounds? I mean, why? What's the connection between having some extra, let's talk about guys. The typical guy who likes his beer while he's working on the deck, or goes out and shovels snow and then comes in and has a little beer.
It's most of my patients.
And he's got a little inner tube around him. What's wrong with that? I mean, that's just a dad bod, isn't it, after all?
Yeah. There's a direct correlation between obesity and hypertension and the incidence of diabetes and so forth. The larger you are, the harder your heart has to work to pump the blood around, so the blood pressure goes up, and the heart.
So there's more
harder.
resistance.
Yeah, exactly. There's more resistance, and several other factors, a little more complicated biochemical, medical.
How about
factors.
Inflammation?
Well, inflammation actually occurs
that's
when
with fat tissue, isn't it?
Well, yeah, but that's a little different because when the blood pressure goes up, there is more inflammation that occurs in the blood cells, in the blood vessels, and the cells of the blood vessels can build up more plaque because of that.
But I'm talking about fat, though. Fat is inflammatory, isn't it?
Yeah, sure. Yeah. Actually, your wife is an expert at this nutrition type thing. She'll tell you about that.
Okay, so fat is not good, and especially visceral fat, right?
Yeah, that's right. And central obesity, they say, is worse than sort of generalized obesity, but any obesity is bad. I'm not saying that any obesity there's any good obesity, but they say especially if you're centrally obese.
So
and
better to be
skinny,
better to be a pear than an apple.
Yeah, shaped like a pear. I've heard that one too. Yeah, you can. I don't know if. And again, I can't promote.
Better
obesity.
to be an asparagus than either of the above. But
I'll tell you, you're a great interrogator. You're wonderful.
You look like an asparagus, right? And I look more like an apple. So you're telling me I'm not going to make it to 95? Is that right?
Well,
all cardiologists. In fact, every cardiologist we talk to, the guys that have written the books, and Dr. Nissenbaum, they're all skinny like asparagus.
I don't know. I think it's genetic, my family, but who knows? I mean,
okay. So
anyway, let's not talk about me. I want to talk about everybody else.
So,
let's talk about
and
my
it
patients.
is, and you talk about COVID being an epidemic. I mean,
That's
certainly
true.
obesity and overweight are absolutely epidemic. Right?
And diabetes and smoking and hypertension, high cholesterol if you don't take care of it with medication. If you need medication, certainly diet. You want to hear something? I have some funny. I had a patient actually last week or 2 weeks ago that came to me and said, I take your cholesterol pills that you gave me for my high cholesterol, and I go and I have a McDonald's hamburger or something, or whatever they say, or some pizza or something like that. I won't say where, but I say it doesn't work like that, because 25% of the cholesterol is you watching your diet. 75% is the pills. About 25% is your behavior, what you put into you. You are what you eat, and that grease and so forth. You have to help the pills do their job. In other words.
So my wife's out of town taking care of the grandkid. So I had a long day. I was up all night the night before. That's probably not good for the heart either.
No,
and then I got home, and I got into the toasted ravioli. It was not good. So should I double up on my Lipitor today, or what?
And it's funny. I hear that a lot, and I tell people, so 75% is a 25% diet. But people will do that. And you're right. And they're not supposed to do that.
But the message I'm hearing is to be serious.
Are you serious? Are you ever serious?
I am always serious. Through humor, I am serious.
Yeah, I love it.
So the pill, though, I think a lot of people think that, hey, if I take a pill, it's an excuse, it's a ticket to then not watch my lifestyle. That's the same as putting ceiling paint over the mold in the ceiling tile, right?
Exactly,
I mean, it's going to bleed through eventually, and there's still a problem underlying.
Yeah, you're right.
Okay.
It really, you can't put a Band-Aid on it. I know what you say exactly. You really have to take care of it fully. A lot of people out there want to live as long as possible, and I get that question. That's another question I get a lot. Hey, doc, what can I do to live longer? I mean, boy, I get that almost every day, if not every day, something like that. And it's risk factors. Okay. What are risk factors? Anything that is going to hurt your body, like high blood pressure, diabetes, smoking, obesity, things like that. Now, remember, there is some called genetics or family history and so forth. If you have a family history, don't be scared. Oh, my God, father died at 45. I'm going to die at 45. That's the last thing you want to do. You want to take the bull by its horns and go through what got your father. Well, he probably had a high cholesterol. He probably had diabetes. Maybe he smoked. So you don't want to smoke. If you have diabetes, you take care of it. See some great physicians we have here at Scotland County Hospital to watch your sugars. And if you have a blood glucose monitor, check your sugars regularly. If they're starting to go up, call your doctor right away for instructions on what to do. Take care of these. If blood pressure's going up, you take care of that immediately. Don't just let it go up and ignore it. In medical, as you know, as a physician yourself, that we can't put blinders on. You can't cover your eyes and say it's not there. I don't see it. I don't see hypertension, therefore I don't have it.
That's the problem,
right?
You
get that too in your practice.
I mean, I guess if it's
I get
high
all the
enough,
time.
If it's high enough, you'll have a headache. I get that.
Exactly, headache, dizziness.
But long
things
before
like
you get to headache levels, it's doing damage, right? How does blood pressure damage the blood vessels?
Very simple. It's like this. If I go up to a wall and I'm punching on a wall, after a while, I'm going to put a little bit of a dent in that wall.
Okay.
Well, if you have high blood pressure and that blood pressure is hitting on your arteries over and over again, nonstop, it's going to cause damage to those arteries. Now, the body's plaster, and every year I talk about this, the body's plaster is cholesterol. That's how you build up cholesterol plaquing. So when there's damage to those arteries, there's little cracks that develop in the walls, in the inside walls of the arteries, and the body's plaster, so to speak, like you spackle in a house before you paint, same idea. Yeah. The body's plastering and spackling is the cholesterol. Cholesterol comes in, a little layer here, a little layer there. You just keep doing that over and over again from the damage, from smashing on as well hypertension or smoking or diabetes or high cholesterol. cholesterol, and you're going to build up some decent plaque. I got to tell you, I just read a carotid artery test, and I look at these carotids. Somebody has dizziness, and I check, make sure they don't have significant blood. I had a 25-year-old with bad hypertension, blood pressure 180 over about 90.
25?
25, yeah, okay. 25. And just last night I was reading it. I sometimes leave here around midnight with all the work I have. It's incredible, but that's something else. I work very hard, but I shouldn't be saying that. That's not the show here. But the point is that I was looking at this last night, and I couldn't believe it. A 25-year-old had a 23% blockage in his left carotid and 19% blockage in his right carotid because of all those years. He's probably since teenagers had hypertension. 10 years of just hitting, pounding on those carotid arteries, the arteries in the neck. That's the arteries going to the brain. The carotid arteries getting hit with all that blood pressure caused damage, like I just described. Right. And the body's plaster, like I just said, so to speak, plaster, which is the cholesterol, was starting to build up in his arteries. At 25-year-old or even 35, 45, shed nothing in there. Maybe you get to about 50 years old, maybe a 5% or a 10%, a little bit here and there. The average, person middle-aged like that, in their 50s, will have maybe a 5-10% blockage. But when you start seeing a 25-year-old like that, you get kind of concerned. So anyway, I took care of him already. I got his blood pressure down. I got him on cholesterol pills, and he's going to take his diet more seriously. But this is what we deal with. And the dizziness he had, actually, I traced back was to hypertension. But thank God I checked his carotids. Not everybody will check carotid arteries with dizziness.
Yeah, I listen to
ultrasound.
You may not know this.
We do it here in Scotland County, by the way.
Us gynecologists listen to carotids too. You may think we only work from the belly button down. You're right.
Okay,
it's frightening to me. I have had that experience. I have to tell you, and it's not to frighten you, ladies and gentlemen, but I have had an experience where a person had blood pressure problems, especially women who aren't symptomatic.
Yeah, that's
I listen to their arteries, and it's like whoosh. Whoosh, whoosh. We call that a bruit, but that means you've stepped on the hose, you've narrowed it, and when you know what it's like when you step on the hose and the water's on, you hear something.
Yeah.
And your doctor should probably listen to your neck if you have those risk factors.
And we check those right here in Scotland County Hospital.
It's part of the employment contract. All right, I'm Randy Tobler. There's Eliot Nissenbaum. When we come back, he'll regale you with a little more of his piano prowess. And we'd invite your phone calls at 660-465-7225, 1-800-748-7875. It's a Thursday morning. The snow is blowing, and we're talking heart disease here on February, America's Heart Month.
Well, this is not me singing. This is somebody else singing.
Stay tuned. Well, we're back with Dr. Eliot Nissenbaum, and here's some more of his wonderful piano work. That's great stuff.
I couldn't make a living doing this.
Are you sure
I couldn't pay the bills.
That's a lot of.
I was a concert pianist years ago, 40 years ago. Whatever.
You've got a lot of keys working in concert.
It's called virtuoso. Well, let me tell you, it's called virtuoso concert hall piano music. It's extremely difficult.
Sure, you didn't have your feet and hands going there?
Well, yeah. I didn't take drugs. If that's where you go with this, no, just me playing.
That's amazing. All right, well, we're talking with Dr. Eliot Nissenbaum.
Wait. Here, this is the best part. This is the best part. Yeah, let me just... Here. In fact, I tell the crowd here. Listen. This is the best part. Yeah, this is the best part. That's extremely difficult. My God. I can't believe I did that. That was after a long day here at Memphis, I saw a whole bunch of patients, drove out to Macomb, Illinois, 83 miles east of here, went to their country club and gave them this piano concert that you're listening to. I was dead tired. I still have no idea how I pulled this off. I mean, playing this.
That's just
7:30 at night.
Talent, as Rush Limbaugh used to say.
Act of God. That's what act of God.
From God.
Exactly. I couldn't do this on my own. I thank God. I could never do this by myself.
Now, that kind of skill and dedication can be brought to your heart and the care of it with Dr. Nissenbaum if you call and make an appointment. In some cases, you need to have a referral. So, work through your primary care physician, a nurse practitioner, PA at Scotland County Hospital, and then make sure that we can connect you with Dr. Nissenbaum. If you feel as though you either have risk factors, which we talked about last segment, or maybe you've had some symptoms. Now, everyone, I think, listening probably knows, Eliot, that if you get crushing chest pain beneath your breastbone, if you have that spreading to your jaw, down your arm, obviously that can be a problem, right?
That's
we
correct.
know that.
That's correct.
But what are some of the other symptoms that may not always conform to the orthodox, the regular, the classical symptoms?
Yeah,
and who's most likely to have those non-traditional symptoms?
That's an excellent point. And yes, to answer your question, it seems that women tend to have these atypical symptoms. However, there are men that have it, but a lot less frequently.
Okay.
What you're describing is typical for men. Central chest pain goes up to the shoulder, radiates down the left arm. Maybe women will get that, but less frequently. Women's symptoms could be a vague, just fatigue and shortness of breath, and a little heaviness, maybe in their shoulder. There's a lady, actually, I had a patient that had a toothache, kept going to the dentist. Dentist says, nothing wrong with your tooth. And whenever she exerted herself, she had a toothache. Wow. And that was her angina. Angina being heart pain, that's called angina. And that was her heart pain.
So we talk about angina equivalents, right?
Exactly. That's called angina equivalent. Angina heart pain, that's heart pain. Equivalent to, that. So women will manifest
that's got to be
more.
Extremely rare. That's got to be Guinness rare, right?
I don't know. It's not. I've seen enough of this that it's not so rare as much as I used to think when I was in training in New York City.
Pain?
What?
Tooth
well, I've seen, not so much tooth, but jaw pain. The left jaw, and even a little bit of the right jaw, but it tends to be on the left side, but I've seen people with the right. I had actually a lady, a Mennonite lady recently, she had, her only manifestation was right upper shoulder pain. That was her heart pain.
Wow.
Nothing on the left. So it's not always on the left. It tends to be maybe 80-90% of the time it's on the left side, but it could be central and more to the right, a few times on the right. But women have this weird manifestation more than men. They'll have these strange, it's not this weird, but generally different manifestations.
Be careful about talking about women and strange manifestations and unpredictability. I'm just warning you. Just
your mind always goes in these off directions.
I have guys sitting in my office with their pregnant ladies sometimes. And how you doing? I say to the patient, and he says, not so good. I'm saying, shut up. Let her tell me.
I want to hear her description.
No, seriously. But I mean, the women do have these atypical symptoms. And what concerns me is they may blow it off.
They blame it on other things. I had, in fact, just recently, a couple weeks ago, women told me, well, I thought I was getting older. Actually, I heard this for two different patients the same week. They said, I thought I was just getting older. I said, listen, it's not, you're suddenly getting trouble like this. It's not you getting older in the past couple of months like that. I mean, everybody's getting older. We are, me, everybody. But why is it suddenly you're going downhill rapidly? Something else is going on medically. And it doesn't have to be coronary. It could be something else. But that's why you have to check with your doctor and do a physical exam, make sure everything's okay. Blood work is wonderful. I mean, I rely on blood tests a lot. I pick up a lot of things on blood work that people don't even know about. New onset diabetes will make you go downhill. But
you have to get your hands on them, or a primary care doctor has to get their hands on them. So you mentioned jaw pain, back pain. Okay. Yeah. What other kind of things that may not be pain related should cue a patient, anyone, but especially if you're a woman, if you're older, you may not have the typical chest pain, right?
That's right.
What other cues can occur?
Well, just suddenly, I've had people tell me that they're just running out of gas more recently.
Yeah, so more fatigue than they're used to.
Yep, exactly. More fatigue. They just don't have the energy they had. And here's another one also we didn't touch on at all here, is that the relatives come to me and say, he just doesn't have the interest to do the things he used to do. He doesn't want to go out to the shed and work on this. He just wants to sit around the house and not do much. And I don't know why. I ask him why, and he can't tell me. He says, I just don't have the energy that I had before, and they just don't want to do much. And that could be coronary disease. It could be a blocked artery, and they just can't breathe as well.
But it could also be depression, right? I mean, but it needs to be evaluated is the point. If there's a change in a person's behavior or their motivation or their energy.
That's right. The heart may not be pumping as well, and they just don't feel as good as they used to.
You know what, though? You and I both know it. Guys don't like to do that. I think women, if they knew, I hope women listening will take these kind of symptoms to heart, pun intended. And if they feel different, if they feel like, wow, I used to be able to, mow the grass and do the lawn, and while the guys with the remote watching football, you know how that goes. And I just don't have the energy, or I'm a little short of breath. They shouldn't blow it off just because they're a few years older, right? I mean, they should be seen. But guys will blow it off and say, what do you mean? So they need to go in and see their doctor.
You know why I'm laughing here? Because it's that old expression all three of us have heard in the room here. Guys never ask for directions when they're lost. Have you heard that expression before?
Yes.
It's the same thing. And look, I'm a guy. I'm kind of a macho guy too at times, not always. But the point is that I will be pretty independent. I'll say I'm I'm okay and so forth. Men are more guilty of that. It's just the nature. It's just our hormones, I guess. But we really have to take these things seriously. It could be life-threatening, and we've saved more lives by really being proactive and doing tests on people like this, really trying to find out what's wrong, and it's very nice.
How about shortness of breath? Just, I mean, like, let's
very
say,
good point.
Okay, so
I
get to thinking about the classic, the guy out shoveling snow, or that may or may not happen depending on how much we get. It's really been unpredictable here. I know south of us it's really building up, but so far I see a little coating outside. I don't see a bunch building up. We'll have to stay in touch with the weather and news people here on KMEM.
True.
But guys get out and they shovel snow, and that's a pretty intense exercise, right?
Yeah, that's one of the most.
So I shovel snow and I'm short of breath and I'm not having chest pain, I don't have jaw pain. Why do I go need to see Dr. Nissenbaum and pay the $800 copay because he plays concert piano? There is a surcharge for that. No, I'm kidding. There is not.
Randy Tobler, you think of everything.
There is not.
I love it. But now, so I'll tell you, and you mentioned the word exercise. That's shoveling snow is not exercise. I don't want people to start thinking like that, because that could be pretty heavy exertional work. Exercise is a nice, easy, onset type of thing. It starts slowly and kind of go into it. Shoveling snow could be pretty intense stuff. You suddenly go out there, get a shovel, and you're shoveling snow. That could be a little too much for people. So I don't recommend they do that for exercise by any means. But
what about irregular heartbeat?
Yeah,
okay. What does that mean, and how urgent should that be evaluated?
I'm glad you brought that up. And there's those new watches now that could pick up on regular heartbeats. There is an entity called atrial fibrillation. A lot of people have been seeing commercials for Eliquis and Xarelto and irregular heartbeats, and they already the public's being educated on the problem with that. Irregular heartbeats could be what's called atrial fibrillation, or AFib for short. And I want to bring this out to the public listening to this right now. It's extremely important. We could prevent strokes by educating the public on AFib, or atrial fibrillation. Okay. Same thing. Irregular heartbeats occur for a variety of reasons. Number one, it could come from a long-standing history of high blood pressure, where your heart goes out of rhythm. You might have heard that term, going out of rhythm, where instead of like boom, 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 like a normal heartbeat, it goes boom, 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 like that, all different.
All over the map.
All over, very chaotic,
so,
exactly.
And people often describe that as palpitations, right?
That's right. So I'll have patients come to me for palpitation. I'll do a workup, and I'll find, most of the time we can find out what's causing it, and we treat it. But if it's atrial fibrillation, the concern about atrial fibrillation, rather than just a few little extra beats that are not atrial fibrillation, is that atrial fibrillation, the atrium does not contract well. It's not that nice, smooth contraction. And when the blood sits around, it doesn't move as fast, which it does. About 20% decrease in your heart function. Blood doesn't move as quickly. It moves, but not as quickly. When the blood is more stagnant, sitting around like in a pond, or not moving quickly as opposed to a river, you could develop clots. Blood clots can form. The blood is, God in His infinite wisdom made our bodies with blood, that when the blood does not move well, it clots, and that's how you don't bleed to death if you get a cut. But the problem is in the heart, if the blood flow is not as good in the heart, that's bad, because then the blood is not moving as well, and you could get a clot, and that could go to the brain. The clot can form inside the heart and get pushed out to the brain. So we put people on Eliquis or Xarelto, or warfarin is the cheaper one, but you have to get blood tests with warfarin. Some insurances don't cover Eliquis or Xarelto or Pradaxa. Well, those are the three that we use for that. But anyway, but it's important, because you got to be on some type of blood thinner like that, more than just aspirin. Aspirin is not good enough for this unless you have a problem with the thinners, the stronger thinners, and you have to only be on aspirin. That's something else. But it prevents strokes. There's enough people that have had strokes that are preventable if they know they have AFib, and they could be on blood thinner to prevent a stroke from occurring. But this is a major league thing. The incidence is about 8% of people who are having AFib over a year will have a stroke of some sort if they're not on a blood thinner, whereas a blood thinner will knock that down to about 2%. And that's significant in the medical field.
So it doesn't eliminate it, but it certainly lowers the risk.
Exactly,
Yeah.
Big time.
So again, I guess the message is, especially if you know you have risk factors, including if you picked your parents wrong, right? If you have a family history or a lifestyle-related risk factor, and you have anything that changes in your life, whether it's pain or whether it's shortness of breath or just pooping out earlier,
that's right.
Go see Dr. Nissenbaum or get into your primary care doctor.
Can't give a shout out yet, or almost? Okay.
We'll come back. I want to ask you about baby aspirin, because there's been recent change in recommendations about that in the last year or so.
That's right. We'll talk about that.
And the guys listening out there, watch them all perk up here. There is every other commercial on radio, well, maybe not this radio, but other radio is about ED and testosterone therapy and everything. Talk about testosterone therapy and heart disease when we come back. As we wrap it up here, talking hearts in February Heart Month here on KMEM Healthy You. Stay tuned, lots more. No, you're not in Branson listening to a Liberace concert. You're listening to Dr. Eliot Nissenbaum, our guest today on Healthy You, and you can see him if you want to be evaluated for heart problems. Many of you may be seeing him, and don't forget, with COVID, a lot of people missed their visits and weren't keeping up with their regular appointments, whether it was cardiology or colonoscopies or mammograms or prostate exams.
That's true.
And so, make sure that you stay on track with that. And if you missed last year and it was time for a checkup, please call the hospital and get on board with him. Wanted to talk a little bit about the baby aspirin.
Yes,
there seems to be some controversy over that, or at least in the lay person's mind. It was very popular. It seemed to be a panacea. Everyone was on it. Everyone over 50, everyone that had a heart hypertension, family history. What's the current thought on who should be on baby aspirin?
Yeah, I'm going to go into say I know.
And this is not a prescription, ladies and gentlemen.
Yeah.
So talk with your doctor. Talk with Dr. Nissenbaum. Anything
right,
we talk about are general guidelines here.
That's right. I have to see. I have to evaluate you and so forth. I'm going to get in trouble if I don't give a quick shout out. Take 5 seconds here. Dorothy Logan. I want to shout out to her first and foremost.
Yeah.
Also, Steve Hilpert and Marsha Monroe and her husband Kenny and Sandra Ebeling also. So I wanted to shout out to them and so many other people that I just love around here. There's wonderful people. I've made so many friends in this whole area and all over the place. I just love all you guys. I love my patients, and they know that. It's not just a word or a phrase. I just love you guys. That's why I'm out here in the Midwest. It's out of choice. I gave up a teaching professor of medicine position in Mount Sinai Medical School in Manhattan back, and I was the first doctor to give that up in 14 years to come out here to be with you guys, to give all the stuff I know. There were 1,000 applicants for 2 spots at the Albert Einstein College of Medicine Cardiology Fellowship. I got one of those 2 spots in New York City. There was extremely difficult. At the end, the Mount Sinai Medical School director, he came to me. He said, "You're very well known in New York City here. Your prowess. You have an aptitude for this cardiology stuff." He said, "I want you as one of my teaching professors of cardiology." And I said, "No." He said, "You're the first doctor to say no in 14 years I've been director here." He said, "Why do you say no?" I said, my values, I'm very conservative. I like the Midwest. I love the Midwest values. I'm a religious, conservative person, and I like the things they like. I like country music, pickup trucks. I like fishing. I like shooting. I got my AR-15 with a scope, and Dr. Wilson and I have talked many times about shooting.
Better watch out about that. They might be listening now at the DOJ.
Oh, DOJ.
Some guys in black coats are going to be visiting your house.
Then I'll wrap up good, but that's the point. I love being out here. What people like here, I like, and I fit in beautifully with everybody around here, and they know I love them, and it's very mutual. Anyway, so let's get back to the aspirin. I do want to know about that. So anyway, yes. Lately, they've had some studies that show that there are more side effects taking even a coated baby aspirin of ulcers and so on than the benefits. But I'll tell you how this works. The American College of Cardiology has really emphasized that it's very, very patient selective. So what do I mean by that? If the patient has risk factors, has known arteriosclerotic disease, they've been found to have, like that 25-year-old I mentioned before with the blockage, he has to be on a baby aspirin for the rest of his life. If you have established blockage, you really should be on a baby aspirin prophylactically coated. Make sure it's coated. If there's no disease whatsoever, they find clean arteries and they don't have risk factors, then they think the risk for an ulcer, bleeding ulcer, could be higher than the benefits of taking it. And that's really what that's all about, if you're curious.
So be careful if you've been on it and that instruction came, 2, 3, 5, 10 years ago. It's time for a reevaluation in view of your current circumstance, your risk factors, and the new information. Okay, good.
Exactly. But if you have GERD, if you have reflux, then you definitely want to reconsider the benefits of aspirin.
That's everyone in the audience. Too many toasted ravioli and
stress.
Pizza. Okay. Before we run out of time, a popular conversation these days is erectile dysfunction, guys getting testosterone, taking supplements. Testosterone in excess can be, I guess, problematic, but But I've also read that there are some data out there that suggests that testosterone therapy may actually be good for the heart. So what's the story?
Let me tell you about that.
Let's say you got a guy that's low normal or just below the lower edge of testosterone, and he wants to just and his doctor wants to get him up into the normal range. I've talked with Dr. Davis about. I said, hey, when you shoot for testosterone, I just try to get him up into the mid range. I'm not going. I don't want him to be like Tyrus.
Well, I'll put it this way: there's benefits, there's drawbacks with testosterone.
Yeah.
The verdict is it's not quite out yet exactly what to do in this regard. I have to agree with you from what I've read in the cardiology journals about testosterone. Just get the level up to the normal level and something comfortable, not just a very lower end, but just something in the lower middle area that they, could do their thing without
that makes
problem.
things functional. Yeah,
exactly.
And by the way, testosterone therapy has a place in energy and stuff too.
Yeah.
That's why if a guy has lost his energy, we need to know: is it because your testosterone's low, or is it because your arteries are blocked? Two wildly disparate reasons.
I'm glad you brought that up, because the influence of testosterone on energy, it does help, but not as much as some other things. Let's say if your blood pressure is high blood pressure can make you kind of tired, much more so than a low testosterone.
So can medicines to treat it too, right? I mean, depending on the medicine.
Beta blockers, sure. Yeah. Certain medications are notorious. Amlodipine also can make people tired, for example.
Don't use beta blockers as much in folks that don't yet have heart disease, do you?
That's right. No, absolutely not. No. ACE inhibitors like lisinopril or ARBs like valsartan, the cardiologists love those drugs because people actually feel good on those hypertensive drugs. They feel good. Certain drugs like beta blockers and amlodipine, which is calcium channel block, make them tired. That's what we do. That's my job.
Now, this is unfair to ask you with only 30 seconds left, but we've heard about the spike protein and the ACE receptor and COVID. Yeah. So if you're on an ACE inhibitor, are you more at risk? Or?
I'm glad you brought that up. They did the studies on that, and the answer is no. Unfortunately, there's no benefit or link.
So stay on your ACE inhibitor.
Just stay on your ACE inhibitor. Okay. They really worked on that heavily, and they haven't found a distinct association.
Okay. So we can take off our tinfoil hats and not worry about that.
Just kind of do your thing.
Well, speaking of ACEs, you are an ACE, and we're glad we didn't inhibit you from being on the air today. Thank you very much, Dr.
I just want to say I love the
Nissenbaum.
people here in this whole area. Great people. I love taking care of them and coming out here in Midwest.
And the number to call, people call the hospital to get an appointment?
Well, actually, it's they call Quincy 217-214-3433, or you call the hospital here directly.
We'll connect you.
Yeah, and they'll work. Google Eliot Nissenbaum piano if you want to hear that piano music you just heard in the beginning.
It's amazing, yeah.
It's Eliot Nissenbaum piano on Google. It's not on YouTube. Of
course, if you were on YouTube, you mentioned AR-15, so you won't be on YouTube anymore. You'll be canceled.
I'll be
all right.
Canceled.
Hey, thanks, Dr. Nissenbaum. Hey, guys, that wraps it up. Be careful out there in the snow, okay?
I'm one of the boys here in the Midwest. I'm one of the guys here in the Midwest. You know what I'm saying?
Be well this week and share it with someone you love. Be careful in the snow. See you next time.